Hello, everybody, and welcome to Practicing Safety Mindfulness Project for Mothers in Drug Treatment, Adapting Interventions in a Clinical Setting. I'm Amanda Hopping-Wynn, Director of the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. Today's webinar will be presented by Meghan Gannon. Meghan is a clinical research coordinator at Nemours Hospital for Children in the Division of Pediatric Population Health. She currently works as a coordinator of Practicing Safety Mindfulness Project for Mothers in Drug Treatment and the impact of mindfulness-based childbirth and parenting on stress and preterm birth, working primarily with women who are in medically assisted treatment for opioid dependence. Ms. Gannon's primary areas of expertise include parenting research and the effect of exposure to childhood trauma on parenting. Before we begin, I do want to remind you that you can ask questions via the chat feature in the lower left portion of your screen. We'll be answering questions at the end of the webinar, but please feel free to chat them in at any time. And now I'd like to turn it over to Meghan. Thank you so much for being here with us today.
Thanks, Amanda. I'm pleased to be here today with everybody to talk about our project. Today I'll be sharing with you all a brief introduction to our AIA project, as well as the adaptations and challenges and the strategies that we've used in implementing mindfulness-based parenting intervention into a clinical setting. As you're all very well aware, I'm sure, the crisis in substance abuse among women of childbearing age is widespread, and it's heavily discussed in terms of policy and research. We also see it daily in the news, and we know that this population struggles within the context of their addiction, as well as the myriad of life challenges that act as barriers to healthy parenting, such as incarceration, mental illness, homelessness, food insecurity, and the fear of losing custody of their child. So all of these challenges, as well as the mother's addiction, contribute to parenting deficits. This parenting population has been described in previous research as having ambivalent feelings towards motherhood, using harsh punitive responses, lacking a basic knowledge of their child's development, and perceiving infant communications as demanding and inappropriate. In light of these challenges that the population faces, Dr. Abatemarco and the other co-investigators of this grant developed a multifaceted intervention that's aimed at improving the parenting of women in substance abuse treatment using 3 different study arms, and these study arms are shown here on the slide. These include work at the pediatric practice where the children receive their clinical care. And here at the practice, we implemented a large quality improvement initiative through a mindfulness-based parenting intervention. That's the second arm of the study, and that occurs at Jefferson's Family Center Drug Treatment Program site, and through enhanced case management. And that enhanced case management and enhanced referral occurs between the social worker at the pediatric practice and the caseworker at the Substance Abuse Treatment Center Family Center. So the intervention outcomes that we're looking at in our study include parenting and maternal psychosocial outcomes, child health and developmental outcomes, enhanced pediatric care, job satisfaction for the pediatric practice, and community care management. And we measure these outcomes through paper assessments that our mothers complete before and after they go through the intervention. And the full intervention occurs at Jefferson's Family Center Drug Treatment Program clinic site, as well as the Jefferson Nemours Pediatric Clinic. So while all of the three different study arms are so important and have produced rich learning for us in terms of lessons learned, I'm going to focus today's webinar on the mindfulness-based parenting intervention arm. So more and more we're seeing mindfulness in newspapers, radio programs. I hear it at least once on NPR a week, television shows, and apps, lots of different apps for iPads and your phone. It's even permeating into schools where kids across the country are being guided in short meditative practices as well as yoga. So what is mindfulness exactly? Mindfulness can be described as an ability to be present in this moment without judgment, to be aware of what you're thinking, feeling, or perceiving. And Jon Kabat-Zinn, who is a leader in the mindfulness movement, describes it as paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. So mindfulness-based parenting is a relational approach that was developed from the principles of mindfulness, and it calls for the full attention of parents when they're interacting with their children. It highlights aspects of non-judgment, compassion, self-regulation, and aims to really cultivate an emotional awareness in the parent. So mindfulness itself impacts intrapersonal and interpersonal domains. And these are both really important for reflective functioning and are pertinent to the parenting role in communication and how the parent really behaves towards the child. Previous research shows that mindfulness-based parenting has resulted in enhanced perspective taking and empathic responding, emotional identification, emotional communication, and anger management. And all of these are implicated and important in parenting behavior. So the tenets of mindfulness-based parenting are to nurture yourself and your child, to attune, which means to listen with full attention to the child, to be aware of your own inner thoughts and the emotions that you're experiencing and the emotions that your child may be experiencing, to accept yourself, to accept your child, and to accept the situation that you're in with your child in that moment, and to respond wisely rather than to react impulsively in the moment. So in terms of our clinical intervention, each cohort of the mindfulness-based parenting took place at Jefferson's Family Center Drug Treatment Program site, and it ran a course of 12 weeks. So for each cohort, our moms met once a week for 2 hours. 3 out of the 12 sessions included a mother-child dyad time, where the moms were guided in mindful play, and they were offered real-time feedback and instruction on their parenting. The moms were eligible to participate in our intervention if they had a child between the ages of 3 months to 3 years. The structure of the group included discussions on mindfulness and mindfulness concepts and different experiences that the moms had and how they were bringing mindfulness into their life. different mindful activities that they would include every week with our moms, and mindful practices. At the conclusion of the 12 weeks, a graduation ceremony is held for all of our moms, and we also hold a celebratory lunch where we honor them and their commitment to improving their parenting skills and their relationship with their child. So to date, we have 14 completed cohorts, and the average graduate that we have in each cohort is about 8 to 10 women. So now that we have the basic understanding of the background of the grant and mindfulness-based parenting and how our intervention works, we can talk about some of the challenges that we face in implementing a mindfulness-based parenting intervention into the clinical setting of Family Center. So one of the biggest obstacles that we've faced in bringing this intervention from being a research proposal to an actual group at a substance abuse treatment center is attendance. Irregular attendance affects the group in a variety of ways. For instance, over time, we found that our group really begins to bond and hold each other accountable and responsible for attendance. So when a mom misses group, the others notice it, and it can affect group morale. So we've had to work with our moms in trying to help them schedule outside appointments for psychiatry or housing, court, and WIC to be outside of group time. That said, sometimes you have no control over these things, and the moms have to miss the group that week to make these appointments. We found that our mothers also face a lack of alternative and reliable caregivers, and this has resulted in mothers bringing their sick children to group and even their older children. So in the summer months when the kids are out of school, we found it's really hard for our moms to come and attend the group without bringing their older child with them. And naturally, when a mom brings her child to the group becomes distracted over the presence of the child, and the teacher has to exercise a lot more energy towards focusing the group back to topic than spending energy on the actual content and experiential pieces. So during these times, we've had to either work with the distraction, whereby the teacher uses this as a teaching moment, saying, sometimes in life we have these distractions, this is how we work through them. And other times, we've been able to use available research staff to help in sitting and playing with the child so that the mom has the space to participate in the class and give her that time so she doesn't miss out on any content. Another challenge that we faced in implementing the mindfulness-based parenting group was helping the mothers understand that the mindfulness-based parenting group is fundamentally different than the groups that they are accustomed to here at Family Center. So the moms come into mindfulness-based parenting with expectations that the mindfulness-based parenting group would be the same format as the groups that they're accustomed to at the clinic. However, mindfulness-based parenting is distinct in a number of ways. First, it's part of a research study. So the rules and enforcement of rules are different than they are in a typical group setting the mom may experience at Family Center. The clinical groups at Family Center hold time for processing, and they have strict rules and consequences for non-attendance and lateness. The mindfulness-based parenting group is quite different as it works with space and silence, and we really try to help the moms reduce the storytelling. So there's not time during the mindfulness-based parenting group for processing. And because this is research, we don't have strict rules about attendance other than if a woman does not attend a session or a series of sessions, she may not be eligible for receiving the incentive that's tied to that attendance. Further, while lateness is discouraged, we do allow moms to come in late to the group because we want them to experience as much of the intervention as they are able to. Another challenge to implementation of the mindfulness-based parenting group into a clinical setting is the difficulty that the mothers have in just being present. Many of our mothers in the parenting groups have pervasive anxiety and stress, which complicates their ability to focus on the material that's taught in each class. So for this reason, our teachers have focused on repetition and simplicity. Key concepts and phrases are emphasized often in each class and articulated very clearly. Due to the challenges that our moms face, the teachers also offer hope early on, really letting the moms know that mindfulness can become a tool that they can use for themselves and their relationships with their children and their family. Teachers also normalize parenting for our moms, offering to the mothers that a lot of the parenting challenges that they face, such as infant crying or frustrations with toilet training or setting limits and rules, anything tied to discipline, that these are really challenges that every single mother, regardless of if she has a history of addiction or not, experiences. Mothers also struggle with body image issues, and they have difficulty sitting still and being present with themselves. So as a result, the teachers have to intersperse movement into the mindfulness-based parenting class to help keep the moms engaged and to release some of that physical tension that the moms always carry with them and the anxiety, so that the moms are better able to really starting to develop a sitting practice for themselves. After running through the first 8 cohorts, we began to develop the idea of an orientation to host for the women the week preceding the start of the group. We saw in the early cohorts that the women needed more clarification up front about how the mindfulness-based parenting group is different than the clinical group that they're used to at Family Center. The mothers also needed more reinforcement about the general roles of the group and what to expect in terms of the structure of the group. Because again, this group is just fundamentally different from the other groups that they experience here at Family Center. So because of this, we began to hold orientations. The orientation is held in the mindfulness-based parenting group room that the moms will be meeting in for the next 12 weeks, and it's led by our case manager. And she is the initial contact for the women in the project and who they go through the informed consent process with. Our caseworker is also the Family Center clinical staff person who sits in on the mindfulness-based parenting group with our teacher. The orientation lasts about an hour, and it covers group basics, such as when the group meets every week, the structure of the group, and our case manager talks to our moms about the mother-child time that they'll get to experience 3 out of the 12 sessions. She also stresses that daily practice is key, even if it's just a 5-minute meditation that the mom does, and she assures them that they will receive downloads to their phone or their MP3 player to practice outside of the group. At orientation, the caseworker also covers the ground rules, such as telling the moms that they always have the right to participate as well as the right to pass. She also stresses confidentiality to our mothers and encourages them to listen respectfully to one another. Women are encouraged to use the restroom before groups so there's less distractions with people getting up and leaving the room. And they're told to enter quietly if they are late and told about some self-care for sleepiness as well. We've also come up with a variety of ways of combating sleepiness because that's a big issue that we face with our population. And we've come up with ideas such as passing a cold, damp cloth to a tired mother to refresh her face, inviting women to stand up if they're tired. We tell the moms that if they see, someone next to them tired, that they can tap them on the leg to help refresh them. And sometimes if the teacher notices that multiple people are a little sleepy, then she will intersperse some movement to get everybody moving around and refresh the group. Possibly the biggest unanticipated challenge and eventual adaptation was the need for a partnership between all of the clinical folks at Family Center and the research staff, especially the mindfulness-based parenting teachers. So as we developed the curriculum and started planning for recruitment, we saw the need to train our research staff who didn't have exposure or experience with mindfulness to train them in mindfulness-based stress reduction. So these staff attended an 8-week MBSR course, and this really allowed them to speak the language of mindfulness, understand the principles and content, because these were the things that would be presented to the moms in recruitment and assessment administration, and we wanted to make sure that all research staff understood enough about mindfulness that they could explain it. It also helped research staff understand some of the challenges that would arise in the group and then be talked about during our regular research staff meetings. The study team also felt that it was important to train research staff in trauma and content such as addiction for the population of moms that we're working with. And this training really sensitized the group to the stigma of addiction and strengthened our commitment to honor our mom's dedication to her recovery. Also, in turn, the drug treatment program clinical staff attended special presentations on the project so they could familiarize themselves with our research. And during these presentations, the clinic staff were guided through brief mindfulness instruction and practices. Now, numerous clinical staff have been trained in the formal 8-week MBSR class as well, which has really aided in the clinic's ability to conceptualize the tenets of mindfulness and how they speak to and articulate them to their clients when they talk about our project. So really, mindfulness has become a bridge and a common language spoken between the clinical staff here at Family Center and the research staff when recruiting our moms. More importantly, we realized the importance of having this clinic staff person in the room during the mindfulness-based parenting group. So early on, it was just the participants and the mindfulness-based parenting teacher in the group each week. However, a few things happened during the first cohort that made us reevaluate how we ran the group. The first was the mothers were treating the mindfulness-based parenting group as they did other groups. They had difficulty reducing storytelling, and many clinical issues were arising during the mindfulness-based parenting group. So we had to then figure out how to manage the clinical issues that were arising in the mindfulness-based parenting group and how to deal with them and which counselor we would go to let them know about what was coming up. And the mindfulness-based parenting teachers were concerned whether the mother's needs, these clinical issues that were coming up in the mindfulness group, were being addressed, and that the bridge between these issues arising in group and then them getting transferred to the counselor were actually being met. So because of this, we brought in a family center clinician to the mindfulness-based parenting group. This clinician sits in on the group every single week and works with our mindfulness-based parenting teachers to ensure that if a mom comes in and she presents to group with big concern or something really weighing on her, she has the option of stepping out of the room with the family center clinician to process it if that's what she needs, so that then she can go into the mindfulness-based parenting group and be able to sit with the material a little bit better. This way also, the clinician knows who the mom's counselors are. And when she, hears some of these issues that come up, she can work with the counselor to ensure that the mom is being followed up with. The clinician and the mindfulness-based parenting teacher also debrief after each session, and the clinician can help inform the teacher as to her reflections and thoughts on what was and what wasn't resonating with the moms that day, and what she saw some of the difficulties and challenges were. So really, the clinician also acts as a sounding board for our mindfulness-based parenting teacher. As I mentioned previously, there were many challenges faced in the early implementation of the mindfulness-based parenting intervention at the Family Center clinic site. Therefore, adaptations were made to the mindfulness-based parenting intervention to assure that the intervention was delivered appropriately and effectively. And this is what I go over on the next few slides. So as it became increasingly apparent how pervasive the impact of trauma was for our mothers, the mindfulness-based parenting teachers and Dr. Abatemarco worked to reorganize the curriculum, to build up the mother's capacity for self-compassion and ego the first few weeks, and then shift the focus more to the dyad and parents. The curriculum was initially developed within a trauma-focused lens. However, it was unanticipated just how pervasive this trauma was until we ran through the first two cohorts of the program. During the first two cohorts, the teachers witnessed the mother's fundamental struggle with her own issues, which really prevented the mom from having the self-efficacy and ego strength to focus on her role in parenting. Mothers were often self-critical of their parenting and felt very guilty of implications of their drug use on the development of their child. So as a result, teachers found it helpful to use invitational language of mindful movement, as well as focusing on the mom's commitment to recovery. The teachers crafted invitational language to use in the group that was gentle and sensitive, such as the phrases here on the slide, such as in your own time, to notice and allow, to be curious about. And this was key for the mindful movement piece of the group, as women who have experienced sexual or physical trauma may not be able to access or focus certain parts of their body. And usually in yoga and mindful movement, women are guided to call attention to certain areas of their body. So teachers also played to the strengths that the women had in their commitment to their recovery, such as the use of recovery slogans and positive self-talk, such as "this too shall pass" and "easy does it." The teachers also found active learning to be the most effective way for our moms to learn, and they used pictures and physical objects to do this. For instance, a mindful practice is described to our moms as being a tool that they can have when faced with a stressful situation. So here, our teachers brought in an actual tool belt, and they put it in front of the class as a visual and had it there the entire time during the 12-week cohort. Another example is a picture that we have in our mindfulness-based parenting room of a surfboard. So the teachers talked to them about urge surfing and how to ride the waves of a stressful situation. And sometimes just the visualization of having the surfboard there helps the moms conceptualize this a little bit better. Active learning also pertains to including mindful movement into the curriculum to a much larger capacity than it was originally planned before the intervention was rolled out. This included making a glitter globe, as well as weekly mindful movement practices and act-out scenarios. And while there's so much content for the teachers to go over, and so much content that they want to go over, they found that they had to really trim the curriculum to be able to transfer key concepts. So they developed several different ways also of providing access to the meditations, such as the use of MP3 players. So our moms were always encouraged to come into the mindfulness-based parenting group room and use an MP3 player to access these meditations. The MP3 player is also an incentive that's tied to attendance. So if the moms attend a certain many of sessions, they're able to take home an MP3 player with the meditations already on them so they can access them at home. We also provided meditations in links via email and text. We found that our moms really responded to texting as a form of communication. And they were also given stickers to use as reminders to have a mindful meditation practice. The adaptations to the mindfulness-based parenting curriculum were largely made due to the women's trauma histories, short attention spans, and low literacy levels. Because of the women's history of trauma, we had to refocus the body scan practice away from areas of the body that are common targets of assault. So due to the short attention spans, we shortened the practices and simplified home practice. To account for low literacy levels, we simplified the language that was used, we eliminated any jargon, and repetitively explained key terminology. In each session, our teachers stressed the role of an informal practice. So mindful practices were also adapted to put a large focus on the breath itself, noticing the breath, telling the moms to become aware of when they might need to take a few breaths to get through a tough moment. We also used the glitter globe activity, which involved the moms making their own globe. So in this activity, moms are guided through adding glitter glue, glitter, and water into a small glass jar with a secure lid. And the glitter is to resemble thoughts and reactions to different people, places, situations. And the women are told to shake the globe. And when shaken, it's almost opaque with all of the glitter and color. And that's to resemble a cloudy mind, one that's filled with thoughts and reactivity. The moms are then instructed to take a few breaths, reminded that thoughts are just thoughts and they will pass, that they can notice them and just let them go without judgment. And after a few breaths, the glitter settles at the bottom of the jar, and what largely occupies the globe is crystal clear water. And that's to resemble a clear mind, a mind that's allowed without judgment to have these thoughts and to be cloudy, but then to be able to release them and to become clear again. The other significant adaptation to mindful practices that we came up with is inviting our moms to practice shortened, eyes-open meditation. So this is really different than a traditional MBSR course because typically eyes are guided to be closed. But due to the trauma history and prevalent anxiety in our moms, in our MBP group, we invited them to practice with their eyes open as it may feel more safe and comfortable for them. So further adaptations include more movement into the mindfulness-based parenting group sessions and adjusting that movement to be trauma-informed. When moms notice a large amount, or when teachers notice a large amount of energy in the room, they integrate movement into that moment, and after some energy is expelled, we found that the moms are better able to sit and reflect on the content of the session. In more formal mindfulness instruction in MBSR classes, instructors touch on incorporating mindfulness in daily life, but really a formal practice is what's emphasized. And here in our mindfulness-based parenting group, we emphasize a more informal practice, as we know the moms do not have general supports at home, such as someone to watch the kids while she has some quiet self-care time. Our moms struggle more with how to incorporate a mindful practice into their daily life, so we try to encourage and talk about them doing a no matter what practice, meaning they could grab 5 minutes to meditate before bed, or maybe when they're taking a shower or making dinner. And we really see these as seeds that they can plant to nourish what may be a more formal practice one day. Where our program really differentiates itself from others is that we incorporate a mother-child dyad piece during 3 of the sessions. This adaptation is seen as necessary to provide the moms with real feedback and provide with their learning in group. It also aims to strengthen the attachment bond between the mother and the child, for the moms to gain insight and experience with mindful practices for themselves, and then guidance and feedback for how they are interacting with their child. And teachers really adapted a traditional mindfulness course here to include this piece to focus really on that mother-child bond. So in general, the adaptations made to the mindfulness-based parenting curriculum that we found to be integral is flexibility in the curriculum. If we see high energy, we add movement. Another is the permeation of mindfulness throughout Jefferson's Family Center Drug Treatment Program clinic, in training staff in mindfulness and trauma-informed care. Maintaining contact with our moms during the week through a weekly reminder email is key for reinforcing the curriculum and retention. And the most significant adaptation that we found is the integration of the Family Center clinician with the MBP group. This really closes the loop on any issues that may arise in the group for the women, and it provides a more integrated approach to treatment. Some of the environmental adaptations that we've made are clearing the physical space, making some poster boards for core lessons, and including some fans and lighting to make the room a little bit more comfortable for our moms and her child. So when we took the time to do this evaluation, we really found rich learning in terms of approaches that we've used to recruiting and implementing our intervention. We've always taken great care and attention to the recruitment process because this is what sets the tone for how the program is received. Our moms have a very vibrant network among them and are local communicators in their experience. So we really knew we just had one shot with the first cohort in terms of the buzz that would be created in the talk about the program. So we had to adjust recruitment strategies over the course of the project to enroll mothers, such as expanding inclusion criteria to include mothers with older children. A recruitment was originally planned to be done by research staff with the guidance of the treatment center director. However, as we worked through it, we decided it made most sense for the caseworker to do this, as she had more direct contact with the mothers and the clinic staff. The caseworker posted signs in the clinic's waiting area and worked with counselors to educate them about our project and engage them to invite their clients to learn more about mindfulness-based parenting. We also expanded our recruitment to our residential treatment setting as a way of increasing recruitment and meeting the request of our moms there. So as I mentioned before, word of mouth travels fast in the clinic. And moms at the residential treatment setting heard about our mindfulness-based parenting program and really wanted to participate. And as a result of all these recruitment efforts, we now have a waiting list of moms who want to participate in our mindfulness-based parenting group.
Meghan, just for timekeeping, we have about 10 minutes left.
Okay, great. Thank you. So orientation was a game changer in terms of recruitment and retention for our project. Mothers initially, a lot of the time, didn't fully realize what mindfulness was until we went through orientation and explained, the format of the group and what they could expect. This really helped to manage their expectations and reduce some of that first-class anxiety that they may have had. We also engaged clinic staff to aid in recruitment and gave counselors recruitment brochures. We even elicited the help of the front desk person in the clinic, which really assisted a lot. Clinic staff were also invited to attend our graduation ceremonies, which are always very moving and emotional. And this really helped to solidify commitment from clinic staff in talking about our program and their clients about our program. Research staff were meticulously trained by experienced investigators of the project in assessment administration, paying really close attention to a trauma-informed approach as well as an addiction-informed approach. Staff were always very compassionate and patient when administering assessments, and we always did a warm pass-off between our caseworker at informed consent and our research assistant who handled our assessment administration. In terms of programmatic aspects, we wanted women to regularly attend the group and therefore had to do a lot of innovative thinking to keep them every week. So we used weekly reminder emails, and we introduced what we called a fast pass that they could earn, which if they came to 4 sessions in a row, they would get this pass, which would allow them to bypass the line for medication in the clinic. And we found that to be really helpful in terms of retention. From a research point of view, assessments are important because they're the only objective measure of the impact of the intervention on the lives of our mothers. And because these are self-report, it was critical that the moms felt very comfortable with completing the assessment. So we made sure that our approach was gentle, supportive, and compassionate, and that we were very selective in who we hired for our research assistant, making sure that this person had considerable experience in working with a vulnerable population. During this process, we always stress confidentiality multiple times so the moms know that they can feel comfortable in answering the question. So in conclusion, when there's multiple barriers exist in working with vulnerable and complex clients, and we found the keys to success to be a multidisciplinary team, lots of communication, especially when working across different organizations, 3 different arms of the study, to make sure that all of the staff on both sides, the clinic and the research staff, had some background in mindfulness and trauma-informed approach, so that we were meeting the needs of our population. To guarantee that we really have the trust of our population and our moms, as well as the trust of the research team, that because we face a lot of challenges, we have to be able to work really well together. And the key to all of this was really the integration of the clinical staff into the research project. This was really what we found to be essential to the success of our program. So I will leave this slide up. This is a testimonial from one of our moms. I think this speaks a little bit better than any results or numbers that we could show you about our project, just hearing it from her mouth. And if anyone has any questions, I'm happy to answer them.
Meghan, we have one question at this
Okay.
point. Can you please describe the difference between storytelling and sharing details about an experience earlier in the week? Is it appropriate for the clinician to interrupt the client if he or she is in the middle of a lengthy story?
Sure, that's a really good question, and that's something that's come up a lot and something that our teachers have really struggled with. So when we say reduce storytelling, we try and get the moms to focus more on their physical sensations, what they're feeling when they're talking about it, and their reaction to it than the story itself. And so what we encourage them is, in 2 minutes, what can you explain, what is the issue, and then talk to us more about how you're feeling about it and how you're reacting to it. And for most of the time, our clients are okay with that, and they appreciate it because the majority of them come into this program and they really want to get some tangible skills in parenting because they really want to be better parents. And so they're used to the other groups, but there's a lot of storytelling, and they want this to be a little bit different. They really want to learn. So they're okay with that. But we have had a few experiences where, mothers have felt that it's difficult when, you're told that you can't, keep going on with your story and everything. And our teachers have found difficulty with that as well in, how do you tell someone to stop talking about something when it's really bothering them? So that's where our clinician comes in, is that when they see that this person is really upset about something, or if the person does keep going on with it, they very gently, go over to the person and say, let's take the time. You obviously need to talk about this, so let's leave the room and process this ourselves. And so that's an approach that we found, that works, but it is really difficult for the teachers because they want to be there, for the mom, but they want to be there also for the group as a whole. And everyone there is there to learn and to enhance their parenting skills. So it's a delicate balance.
Thank you. Can you provide some information on the 8-week mindfulness-based stress reduction course that staff participated in?
Sure. So that there's multiple institutions across the country. We're lucky that we have one just a few blocks away that we've partnered with and have ties to. But the 8-week mindfulness-based stress reduction course is really a foundation course in a mindful practice. And so you go, and it's every week, usually for about 2 weeks, and it's a larger group setting than our mindfulness-based parenting. Typically, MBSR classes can be like 20 to 25 people. And you have some experiential piece where you're guided through meditations, and body scans and mindful movement. And then there's time to talk about, like they ask you to popcorn, so things that come into your head after you did a meditation. How was that meditation for you? And then the group talks about it. And during the 8 weeks, you also talk about how you see mindfulness, that you would use it in your life, and different tools. And you're given different activities, exposure to activities and experience in activities through the 8 weeks. So you start to figure out, okay, this type of a meditation would work for me. Wow, maybe this other type, this might not be right for me at this time. You're given handouts, and it's a lot of experiential and practice.
Great. Meghan, thank you so much for this webinar, and thank you to all the participants who are on the call with us today. We do greatly value the feedback of participants, and we'll be sending out an email in just a few moments. And in that email, you'll find a link to a survey. If you could please complete that at your earliest convenience, we'd love to hear what you thought. There is still time to register for our other sessions in our Lessons Learned series brought to you by AIA grantees. We have 4 more sessions today. You can visit our website, aia.berkeley.edu, for more information and to register. Again, thank you, Meghan. I really appreciate it.
Oh, thank you, everyone.